Prof, how are you?
I'm very well.
Uh,
Oh, thank you. Thank you for being with us.
yes, yes,
You are,
definitely.
you are coming in March, eh? No,
Ah,
February? February.
February. February.
Good, good, good.
Okay,
How was Cebu?
very good. Fun. Very
Lechon,
good.
Lechon was very good, or not?
Whole thing is fun.
Okay, great.
Yeah, yeah. I enjoy myself.
Okay, we have, okay, there are people coming in.
Yeah.
Let me see if there anybody that need to be upgrade in the list of attendees. No, no. Okay. Oh, okay. So anytime we can start. Maybe we wait for 5 minutes,
Yeah,
few minutes.
sure. I'm slowly picking up. 23,
Yeah,
24.
27. Yeah, people slowly are coming in. Okay, 30. I'm checking if there is anyone. Should be okay. We need to prepare a certificate, template.
Email to them.
Yeah.
Yeah, Prof,
Okay,
ready, start?
let me start. Okay,
Yeah.
thank you, Mark. Okay, good afternoon to everybody, for all the participants to be here. And we are very glad honored to organize this workshop dedicated to our healthcare allied, the nurse and all the team that work in OR with us are the very important people. And of course, I need to thank also Dr. Mark from IPO and Dr. Sujit, Dr. Low for being with us. The workshop is organized and tailored to be lasting a couple of days, two afternoon, today and tomorrow. We'll be mostly focusing on minimal invasive surgery training, how to set up OR. Is mostly focused and targeted to all of you, all the OR team, and also an overview on laparoscopic troubleshooting in different kind of procedure. Tomorrow will be focused more on endoscopy, on flexible endoscopy, that is also part of our curriculum. And without further delay, I think it's a good time to start and share some slides and knowledge with all of you. If you have any question, you can use the chat. You can ask. You can use the chat or the Q&A to interact with us, and we will reply to you live or through the chat itself. Thank you very much, and I leave Mark and Sujit to continue.
All right. Thank you, Prof. Thank you for being with us here, guiding us through this thing. Well, my name is Mark. I'm a surgeon from Ipoh, Malaysia here. And I've been discussing this with Prof for some time. MIS is going a long way, it's going far and wide, but we tend to forget our nurses who's always been there, pushing this thing forward. So I had a talk with Prof, and then it's a good time to have something dedicated to the nurses. So we'll start something simple, and then as time goes, try to incorporate something, the curriculum to be a bit more and extensive for it. I also must thank Dr. Sujit, Dr. Sajid, Ms. Emma for helping us out, and Inshira also with all the registration. So I won't take much of a time. We move on to the first talk with Dr. Sajid, MIS surgeon here with our team. But unfortunately, Dr. Sajid is he's got prior engagement, but he was nice enough to send us a video of his talk. All right, so we'll start off with Dr. Sajid's one, talking about introduction to MIS and laparoscopy. Give me a minute, I'll share his talk.
This is my hospital, was my hospital in 1885. This is currently where I am working, and this is what we are expecting, just like my presentation in terms of the MIS training and what would be the future. My name is Dr. Sajid Malik, and I'm currently working as a consultant of a GI and bariatric surgeon in South London, and working at the chair as ICC committee of ELSA as well. I have no disclosure. I asked Google AI and ChatGPT what are the nurses training in laparoscopic surgery in Singapore, and to my surprise, it says that the nurses can receive laparoscopic surgery training by contacting the Endoscopic and Laparoscopic Surgeon of Asia Society, ELSA, which offer workshop for the nurses on MIS. I think we all need silence into the OR theater for the concentration. And the main person who is responsible for documentation, checklist, and all the safety precautions are the nurses team. That's why the nurses are forming the pillar in the operation theater. Who is an IT?
Mark, the sound is not there. Can you check?
Exactly.
There's no sound?
And what would be the
Okay.
next step?
It's good.
Okay.
Ideal nurse need in every procedure phase. She can check, and she's the main pillar in a day case surgery. Otherwise, the patient would be feeling themselves on a roller coaster. She helps in positioning for the laparoscopic surgery to avoid pressure sores and for an optimization of position. She does need during the surgery as an assistant, as a also as a guider and troubleshooter. As I said, even after the surgery, they would be required as well. So it's basically a teamwork, and this task cannot be achieved without a teamwork. If there is no teamwork, that can lead damage to the instruments, to the patient, to the environment, and would not be able to achieve an optimum conditions in a theater. As we all know that, this is a trigone of the surgeon, nurses, and anesthesia, and the proper care and handling in the OR is not only responsibility of a nurse around the patient, but also the surgeon and anesthesiologist as well. But the nurses makes a pillar for that trigone. So what are the trends in the nursing education so far? Currently taking place and influencing nursing profession as a This is a study recently conducted in UK in 2018, and very interestingly, among 276 candidates, 248 mentioned that they don't have a knowledge or have not gained any MIS or day surgery education. Rather, they have a bachelor in the nursing without a proper training in MIS. So I think that is important to go with the mentoring for nurses in MIS. And I recently come across this book endorsed by the Italian Society of Endoscopic and Laparoscopic Surgery for a scrub nurse in MIS and robotic surgery. Why is it important? I think not only for the services, but also for the nurses to develop their education, direction of the issues in nursing mentoring. I think the main issue is we need a nurse trainee who is passionate to go for the MIS training. We definitely have a shortage of staff as a nursing mentor, and increasing competition for the placement qualified graduate nurse, mushrooming of the nursing colleges and the schools as centers, not only for the surgeon, but also for the MIS training nurses as well. So strategies to address the faculty, we need MIS trained surgeons who run the incentive program for the MIS nurses, and there should be online resources available, which promotes advanced nursing practice. And for the nursing team to develop, we should create a dedicated MIS team with more public and private partnership. Main emphasis should be using technology as a training tool and designing more flexible rules for the nursing along with the curriculum. Because if we work together with the schools to increase the interest in nursing career, that will ultimately is going to pay back. Of course, financial support would be important. ELSA have a basic model, which is not only for the surgeons, but also for the MIS training nurses, which provides the e-learning platform for the endolaparoscopic surgical education. So e-learning, is it an answer? Of course, I think it provided the 75 to 80% access, and it's mostly free, especially for the basic training. It allows for the incremental performances and satisfactions. It gives an advantages because the content are created by the faculty. It has a collaborative learning approach, and a dedicated MIS team is involved into creating. Of course, it has a shortfall. If you are computer illiterate, won't be able to go through all steps. Solution, I think, is a hybrid learning. as a theoretical module, and hands-on training program. By designing a course which involves a standard curriculum according to Asian regulation with dedicated surgical videos created by the experts of the online theoretical module. This is another course available in Europe, which is called Lab Nurse, which is a blended learning course for the nursing education in MIS, which is designed by the expert in Spain, Portugal, and Italy. In India, UAE, and USA, the World Laparoscopic Hospital, which is also providing laparoscopic diploma for the nurses. Of course, under the umbrella of ELSA, the e-learning platform is available as well. How does it help? I think the procedural time decreased to 10 to 20%. Surgeon cognitive load decreased significantly, and there's a marked reduction in equipment damage and intraoperative disruptions. So we cannot assume mastery. We must build it, starting from basic OR skill, using MIS technology, and then adopting the skills. Last few slides onto the nurse's role in robotics. Of course, they need a clinical practice, but main emphasis is into the education, management, and the research. If they don't take part into this activity, they won't be able to proceed to the next. So they are further divided into the 4 categories, which is the training. Level 1 is a training module. Category 2 is when there is a compliance with the technology in robotics. Category 3 is when they are ready to changing roles into the robotic surgery. And the category 4 when they are part of the future into the robotic surgery. So what to do? I think we need to create learning opportunities and promote educational programs for the nurses. In conclusion, investing in specialized MIS nursing training is a direct investment in surgical services, efficacy, and patient safety. Thank you so much. This is World Congress Endoscopic Surgery slide for the which is coming in November. I would like to invite all of you. These are the QR code for the ELSA app for the Apple and Android user. If you can scan it, you would be able to see whole of the program and all the educational activities. Thank you so much.
All right. So we just thank Dr. Sajid for preparing this for us. Though he's not able to be here, you can all direct your questions or those slides to the email, and we will try to answer them as we can. All right. Moving on, next we have the topic OR setup. Unfortunately, Dr. Rishikesh is not able to join us today, and his talk will be taken over by Dr. Sujit. Dr. Sujit also is an active member in the ELSA committee. He's a MIS surgeon, hernia surgeon, as well as endocrine surgeon. So he will be talking to us about OR setup. Dr. Sujit.
Yeah, thank you, Mark. Let me share the. Yeah, you can see my slides. Mark, can you see the slides?
Yes, Sujit, we can see the slides and your voice.
Yeah.
Thank you.
Okay, perfect. Thanks. So I'll combine a bit of Rishikesh part as well. So these are my objectives, and so I'll spend a bit more time on OR setup. Basically, I'll show you a video where we can navigate through the OR to see what's going on. So background and importance. So hernia essentially is a protrusion of abdominal contents through a defect in the fascia or the muscles in the abdomen. So the common types are inguinal, femoral, and ventral, and there's incisional. So there's umbilical, there's paraumbilical, there's lateral ventral. So anyway, so so when it comes to repairs or when it comes to OT setup, I think the most important thing is, are we going to do these cases? So if it's a groin hernia repair, then we usually put the camera setup in the patient's foot end, which I will show you. If it's a ventral hernia repair, usually the camera goes on the side. And there's other things that involves as well, like the equipments and all these things are slightly different for these two procedures. So why laparoscopy? Why we do all these things nowadays using minimal access techniques is basically because they gives less pain, quicker recovery, and it allows them to get back to their lifestyle much earlier compared to much, the more mobility associated with bigger incisions and scars, and lower infection rates, and of course, better cosmesis. When we talk about the types of hernia, so we can classify them into inguinal, as I mentioned. There's two ways that we do these operations when it comes to MIS techniques. There's TEP and TAPP. Open repairs, of course, is different. So we do it with incision at the groin crease. But these laparoscopic repairs we do with keyholes or laparoscopic instruments. And the access is usually for TEP is infraumbilical. And for TAPP is also infraumbilical, but we go into the peritoneal cavity. But in TEP, we just stay just under the rectus muscle and above the peritoneum distally. Ventral incisional hernias, the most common technique that's used still is IPOM technique or IPOM plus technique. The IPOM stands for intraperitoneal onlay mesh technique. There's ETEP, which is coming up, and some of you have probably seen us do ETEPs, and the technique is slightly different from this, where we stay just under the rectus muscle for ETEP, but IPOM technique, we are actually inside the peritoneal cavity. Then some of you may have some experience or seen robotic repairs. So robotic repairs are either TAPP, transabdominal preperitoneal, or some of these cases we do in the same TEP plane. We call it robotic ETEP. Okay, so these techniques are now growing in Southeast Asia with the availability of the robots. Basic surgical principles is mainly adequate exposure and clear anatomical landmarks. So some of you may have seen that we draw these landmarks before we put the ports in. We draw the hernia defect. So this gives us a 3D view of what we are expecting and what we are planning. And the next step when we get access is basically to reduce the hernia contents. And the most important thing for this step is identify where the neck of the hernia is. So once the hernia contents are reduced, we usually close the defects in most of these hernia and then ensure a wide mesh overlap because this prevents recurrence. For mesh fixation, again, you would have seen so many techniques that we use. Sometimes we use combination of these techniques. We use suture passes, we suture, we use tackers, we use glue. So this is catered to the patient and the patient's condition and the hernia. So that's when we decide which fixation technique can be used. It's very important that the surgeon has a good idea of where the nerves and the variations of the nerves are, and also it is important to avoid nerve injuries and vascular injuries. And some of the nurses here, you would have seen vascular injuries happen, and some of you have assisted us during these cases. So it's important that we focus and get the equipment that we need to either suture or we apply clips. So this needs to happen quite fast. So then the bleeding can be controlled, and then you can continue with the surgery. Instruments, equipments, later in the video, we can go through some of this. So we have trocars, balloon dissectors for TEPs, not so common. We usually use blunt dissection with the laparoscope. The laparoscope we usually use is a 30 degree, 10 millimeter. but we can also use a 5 millimeter laparoscope with a 30 degree. And we need the insufflators. Dissection is usually done with the blunt, heavy graspers. Some of us, we like to use scissors, and energy is an important component because we need energy to control bleeding as well as to cut through certain tissues like fascia, and also to cut the sac in inguinal hernia. So these are the main instruments that we usually use. Measures are usually lightweight. Composite measures are needed for IPOM Plus technique. And nowadays, there are some absorbable measures available, but these are quite expensive. So most of the time, we use non-absorbable measures, which is the usual practice for the last 2 to 3 decades. Again, fixation, I mentioned what we use. So OR setup, if it is a TAPP or transabdominal preperitoneal, so what happens is that we go in with an infraumbilical incision, and the two 5 millimeter ports we usually put just above this 10 millimeter port, and we usually put it at the flanks so that there's enough space and we can achieve a triangulation where we want to do the surgery. So if the surgeon is doing a right inguinal hernia, then the camera is actually at the patient's right foot end. The camera holder is standing at the patient's right side, and the surgeon or the operating surgeon operates from the patient's left side. If it is a left hernia, then the TV goes here and the surgeon goes on the other side. If it's TEP, what we usually do is if we do a bilateral TEP, we like to put the we like to put the TV at the foot end of the patient. If it's just a unilateral hernia repair, then the TV goes the same side as the hernia. So in this case, it's a right hernia, so the TV is at the right side of the patient. The camera holder usually stands at the same side of the surgeon, and the surgeon uses these two working ports, which is usually in the midline, and does the surgery. If it's a ventral hernia, if it's IPOM plus, we use a flank incision, and that's for the 10 millimeter, and usually we use 5 millimeter 2 ports either side of this 10 millimeter port, and the camera is actually facing the TV is actually opposite us, the surgeon and the camera holder. And in most of these cases, it's important to have another additional TV to mirror. So in case we want to look at the other side, we want to put another port here, then it's important that we can have another television or another screen so we can see what's going on to do these surgeries effectively. And the access for ventral hernia can be from either side of the patient, depending on where the defect is. So if the defect is closer to the patient's right side, then we would like to stay on the patient's left side. If the defect is closer to the patient's left side, then the entry will be on the opposite side, and the camera and the surgeon will stand here, then the TV will go to the opposite side. So let's now take a look at some of these items that we would encounter. So this is a 3D case that is recorded, and this is recorded in our own OT.
Discuss a case.
So what you can see is a TEP being done. So you can see the camera is here. It's a 10 millimeter camera. So two 5mm ports are placed in the midline. This is a smoke evacuator, okay? And then this is an instrument called bisect, okay? And this is how the gas insufflation comes in, the CO2 insufflation. You can see it here clearly. And it goes into the patient's foot end, and it basically enters the insufflator here. So you have a gas insufflator here. then you have the camera, then you have the light source. So these are the main components of this surgery. Then you have the screen at the foot end of the patient. So this is actually a bilateral hernia. That is why we have this table at the foot end of the screen at the foot end of the patient. And you have the nurse's table here, and then you have some of the instrument that we use here. This is the CO2 gas cylinder. So the CO2 comes from here, goes through the insufflator, and then it gets filtered and then pressurized and then transferred to the patient. So this is how the OT set up. So you can see I'm doing the patient's right hernia on this side, and my assistant is standing on the patient's right side while the operating surgeon is standing on the opposite side. Okay, so the anesthesia doctors are here. Okay, and so that's basically the OT setup. So if you go beyond, so you can see how the surgery is done. So when we enter, we usually have the OT lights on, and when we move on to the laparoscopic view, we turn them off and then keep the light level in the room slightly lower so we can concentrate on what's happening on the screen. I'll go through in detail about these three components, which is the insufflator, the light source, the camera, and we will have an energy component here, or you can put the energy, the electrosurgical unit on the patient's right arm. Yeah, so let's go back to, so that's basically the OT setup in a TEP. Okay. So you can see that I'm performing the other side now. So this is the patient's left side hernia being done. So you can see the surgeon is now on the patient's right side. The camera holder is on the patient's left side. And the angulation has been changed. The ports are the same. This is a suction device sometimes we use. Okay. Okay, now let's go back to the slides and let's go on to the details. So we went through the OT setup for the common hernias that we do. So if it's an E-tap repair, what we usually do is we enter with a 5mm OptiView camera here, or you can enter with a 10mm open cut down technique as well. But what we usually do is we enter at the patient's right hypochondrial region with a 5mm OptiView. Then we put another 2 ports below, and then the middle one we convert into a 10-12 port, and then we carry on. So it's almost the same, but for ETAP, we usually have another 5mm port on the opposite side to help with the suturing. So what are the nursing consideration? So it includes the entire journey of the patient, preparations. So it includes addressing patients' expectations, to make sure the consent is up, is correct. The fasting times needs to be educated to the patient, the convey to the patient. Some of the incisional hernia, we require bowel prep. And most of our groin hernia repairs, minimally invasive techniques, we ask the patient to empty the bladder just before going into the theater. For longer operations, we use calf pumps, and because we use a mesh, and we usually give 1 dose of cefazolin for most of these patients. Position is usually supine, and the patient is actually strapped across the thighs as well as across the chest. So usually 2 straps are used to secure the patient. And if there's going to be extreme positions, then it's important to place foot plates to foot at the foot end to secure the patient, or you may even need to use additional securing measures to prevent the patient from sliding from the table. Padding to pressure points, these are very important. Otherwise, patients may get neuropraxia. So it's very important all the pressure points are padded. For usual bilateral hernia repair, we basically use a gel pad to tuck in the patient's right arm. The left arm is usually out so that the anesthetist can use it. Then we go through a checklist. So this is usually done during the timeout, and we check the camera, we check the light white balance, we check the insufflator, make sure suction is available, and electrosurgical unit setting is done. And we also confirm the measures and the fixation devices are available. If you are doing a case that is not very usual, say a complex ventral hernia, we usually go through this checklist the day before or at least 1 week before to make sure the relevant measures are available and the relevant fixation devices are available. Okay, so this is the usual setup that we use. You saw in the video that this is the TV screen. Nowadays we have 4K, so the clarity of the image is much better. And on the laparoscopic stack, this is what you usually have. So this is where the input for the camera comes in. In some of the laparoscopes, like the Olympus Endo-i, this comes in inbuilt to the camera head. But in some cases, we have the light source comes in separately, and then the camera output goes back separately. So in the case that you saw, it was an Endo-i. So the light source joins the camera head basically with the same wire, and then connects into the camera head. So there's some settings that you can see. So if you are not using, you can put on standby, and before you start, need to make sure that you do a white balance, so that otherwise you may start seeing certain tissues in different colors. So that's important that you do a white balance first. This is the insufflator. So you see a few things here. You see the volume here, you see the amount of gas here. So in this case, only 1 bar left. So it's not a good way to start the case. So ideally, you should have at least 50% of the tank when you start a case. The pressure that we usually use is between 10 to 12. So 15 is usually a bit high. So this is in millimeters of mercury. And the flow rate, it can be low, medium, or high. So we usually use medium. High is rarely used. Low if you want to check for some bleeding. Then you have the volume here. Then you have the start button here. And then we usually use the normal setting here, which if you are doing this if you are doing a laparoscopic procedure in intraperitoneal cavity or even TEP, we use the normal setting here. Then you have two types of energy electrosurgical units here. This one is from Erbe, so you can select bipolar versus monopolar. You can put here the amount of energy that you're going to use. So in this Erbe, it comes with a range of 1 to 10. And in this Olympus one, it comes in watts, so it comes from 0 to until 100 you can use. So this is advanced energy device. So you can use advanced energy device called Thunderbit in this one. So this is the entry points that you connect the device. Okay, so intraoperatively, what's important in the nursing role is basically discuss with the surgeon. So we usually have our own cards that we share with the nursing team. So it's easier for them to prepare for the routine cases. So if the case sounds a bit unusual, then it's important that the nurse as well as the surgeon has a chat before and decides which additional instruments are needed, and stand by that those other instruments that the surgeon may think would needed later on in the setup. So it's also important that the team monitor the neoperitoneum pressure. Sometimes the CO2 pressure can change, the patient may start straining, and the nursing role on the other side, where the anesthetic nurse, they will monitor the entitled CO2. So if the entitled CO2 is going up and up, it's good to bring down the pressure and the flow rate so that the anesthesia can catch up to wash off some of this carbon dioxide. So nursing helps us basically to maintain visualization. So sometimes there's smoke accumulation, and if you have a smoke evacuator connected, then we have to control the suction of the smoke evacuator, or if there's no smoke evacuator available, then it's important to just open a port. Just tell the surgeon, coordinate and open a port so some of the smoke can be evacuated. The lens we do clean, we can use hot water. We also have specialized anti-fog that we use sometimes. So this is where the nursing role comes into play during the surgery. So it's important that we communicate clearly and promptly when there's a complication. So if there is a complication, the surgeon needs to give very clear instructions on what he needs and what to expect. And if there's too many people talking, then that actually delays the action that needs to be done. So it's important, if there's a complication, get together and let the surgeon advise you what exactly he needs. So clear communication needs to be done in order to get hemostasis achieved, or to prevent these complications, or to repair or settle a complication intra-op. In addition to that, charging is an important part in our practice. So if during the process, usually what happens is the nurses will record these implants or the consumables. So if these are not recorded properly, then this will affect the P&L of that institution. So it's important that we do record this properly, the measures, the consumables, so that the charging can be carried out properly and in a timely manner. So what are the common challenges? So there can be access difficulties and there can be issues with the trocar placement. So access difficulties, then sometimes there can be issues with the instruments. So we do check this during the timeout. But if there's any issues intra-op, then it's important that the team discuss together and then take the necessary measures, or get a replacement access, replacement trocar in order to make sure the surgery goes on smoothly. Peritoneal breaches are some issues during TEP repairs, not necessarily in other conditions, surgeries like TAPP or IPOM plus, because once you have a small tear in the peritoneum will come to flat onto the camera and reduces the space that we have. So it's important that we communicate with the surgeon, and then usually we either make the tear slightly bigger, so the air can communicate with both cavities on either side of the peritoneum, or we reduce the amount of air in the tummy, we suction and put a clip, usually a Liga clip, to prevent air from coming out. Some of you have seen some of these complications like inferior epigastric vessel injury, corona mortis injury. So it's important that you communicate effectively with the surgeon. So surgeon needs to take charge when there's a complication, and then give very clear instructions on what you need and what your assistant needs to do in order to prevent a catastrophic bleed. So sometimes we use some gauze to press on the corona mortis. If it's inferior epigastric, we either use energy or we use a clip to ligate it. Visceral injuries, bladder injury, bowel injuries. So if you see bile, that's not a good sign. So communicate with your surgeon effectively to get these things repaired. Bowel injuries sometimes even need a laparotomy to fix. Bladder injuries, if you have the skill, the surgeon can do suturing of the injury and later on place a urinary catheter. Nerve injuries, mesh unfolding. So some of you have seen when we basically reduce the CO2 pressure to check whether the mesh is holding properly. And sometimes we ask you to re-insufflate to make sure that the peritoneum doesn't go under the mesh in a TEP, so that the patient gets an immediate recurrence. So in these cases, communication in the team is very important, and the surgeon needs to provide clear instructions to the team. Some of this we discussed. For small tears, what we do, large tears, one option is to convert to TAPP. So prevent loss of working space. You can lower the insufflation pressures. That's one. So the nursing role is basically to communicate effectively and clearly with the surgeon, and And if you're providing a clip, so make sure the clip is properly placed in the clip applicator, and provide the necessary sutures, and so that the surgery can go on. Troubleshooting, again, we did discuss some of this. So recognize it early, maintain the visualization. Sometimes if it's an arterial bleed, it can spurt onto the camera. So we have to be quick to get the camera clean, and then reduce the amount of bleeding and to carry on with the surgery. If it's uncontrolled bleeding, sometimes we may need to convert to open surgery, or even ask a vascular surgeon to come in, and they may use some endovascular techniques to control this bleeding. Difficult dissections, again, go back into the landmarks, use blunt dissection as much as possible, minimize using energy during dissection. Stay within the correct tissue planes, and sometimes when we encounter more bleeding, that's because we are in the wrong plane. So if it's unsafe, then you should consider conversion to a TAPP in a groin hernia if you're doing a TEP, or even consider open repair. Nursing role in this case, in most of these cases, is to have proper communication with the surgeon, and it should be a proper team communication, and then adequate instruments needs to be available, and then need to provide those instruments on time. Mesh placement, again, we discussed before. So the mesh cannot be folded. Mesh needs to be nicely flattened, and fixation should be avoided over nerves and vessels, and type of fixation is also important. Some straightforward hernia in the groin usually don't even use fixation, or sometimes we use glue. So it's big hernia, we even suture the sac sometimes, and then we use stackers for fixation. Post-operative nursing care, the pain is a very important thing, and we usually start pain control intraoperatively. When we start the skin incision, we give local anesthesia, so that reduces the amount of opioid analgesia that the anesthetist needs to give. Then we use certain blocks, so this is standardized in some of our hospitals, so we give these blocks to reduce the pain and the amount of opioid painkillers or opioid analgesia that the anesthetist needs to give. So the issue with opioid analgesia is that the patient becomes a bit drowsy, and then they start to have nausea, vomiting, so very unpleasant experience for these patients. So that's why it's important that we have our own protocols or standardized protocols for pain relief by using local anesthesia and nerve blocks. Early mobilization of the patient and to prevent falls. So the first 4 hours are critical for these patients, because the general anesthesia hasn't really weaned off. So during this period, the patients needs to be assisted when they walk, and need to be properly assessed whether to see if they're independent to go to the washroom, pass urine, things like that. Diet, again, the nursing needs to assess whether these patients are alert enough. If their airway is secured, would they aspirate if you give them a diet soon after they wake up? So usually the first 4 hour after GA is an important area where the nurses need to assess these patients and to make sure that the relevant precautions are taken to prevent falls and also aspiration, things like that. Some of these patients may go into urinary retention. So we do perform PVRU, post-residual urine volume. If it's usually more than 600 ml, most of these patients may require catheter insertion. Currently we don't do in and out for these patients, because especially if the patient is elderly, if the bladder is distant to more than 600 ml, it will take some time for the bladder to recover. So we give them some antibiotics to prevent catheter-associated infections, because there is a mesh, and then we usually bring them back 1 week later to do fill and pull on arrival. And educate the patients on wound care. So most of our patients in NUH and Alexandra, for the wounds, we use glue. So there is no real plasters applied for most of these patients, so they can shower on it. and then need to advise them if there's bruising, bleeding, or any discharge, come and see us in the clinic earlier. So this is our recovery pathway. The nursing team usually advise our patients on what they can do. First day, take it a bit easy. Just rest in the bed. You can walk if you want to the toilet and then come back. If you want to start doing some work, day 2, day 4, you can do some desk job. If they want to fly off, usually after 1 week they can fly. Running and activities that doesn't need a lot of force, they can start after 2 weeks, but those strenuous activities usually starts after 4 weeks. So this is our recovery pathway. So role of nursing in surgical team. So ensure safety, efficiency, sterility. Sterility is very important because we use implants in these cases. Actually, is very, very important. If there is a wound infection or if there are a mesh infection, the patient's life is going to be a nightmare, and so is most likely the surgeon's life as well, because nowadays litigation is going high. So anticipate the surgeon's need, discuss in advance, make sure you have clear communication with the surgeon. And if the surgeon is not communicating clearly, please tell the surgeon about this. Please provide feedback, because the communication is the most important thing in these surgeries to carry out safely. So support during troubleshooting, anticipate what the surgeon may need next, and keep them standby. So provide continuity in pre-op and post-op recovery, and educate and reassure the patients, because it's their mindset that's important. So you set up their mindset from pre-op until post-op and until their discharge. Take-home messages. Laparoscopic hernia repair is safe, effective. Most of you know this, you have seen that, and you have seen how active patients can be after these surgeries compared to big open scars. Nurses play a vital role across the perioperative phases, pre-op, intra-op, as well as post-op and recovery. Anticipation and quick troubleshooting reduces the risk, and always prioritize the patient's safety. Thank you. That's all. I'll stop sharing now. Mark, over to you. Thanks. If there's any questions,
you.
I'm happy to answer, or you can type in the chat. Thanks.
Thank you. Thank you, Sujit. Very nice and comprehensive. Okay, we're moving on next. So I will, because Dr. Sujit combined two talks, so I will bring you back to the introduction, and then basically introduce those who are not familiar to various parts and the key components of laparoscopic surgery. All right, so in the next 20 minutes, we'll go through the aims, the whole concept about laparoscopy, just a little bit on the OT setup, and spend more time on the instruments, certain procedures, and specialized instruments as well. All right, to start off with, what's this whole concept about laparoscopy? All right, so in plain terms, what the general public will say is keyhole surgery. Other words to describe will be minimally invasive surgery or minimal access surgery. Now, why did it take off so much, this whole world of laparoscopy? First and foremost, it overcame many traditional concepts. For many years, things were done in a certain way, and this really took the whole field of surgery by storm, right? Once you introduce something new to the surgical field, you got to make sure it's safe. So over the years, many surgeries have been introduced through the laparoscopic method, and it was found to be safe. So as long as it's safe, no harm to patient, these procedures started to become more and more popular, and many centers are now adopting it. All right, but the key important thing is we are able to perform the same surgery through a large laparotomy wound, but this time the same surgery through smaller wounds and smaller access. So that basically revolutionized the entire field of surgery. So we understand smaller wounds, patients recover faster, and that is a big plus point for the patient. And ultimately, outcomes seem to be better because of the pain control, the early return to activity. And another good thing is laparoscopy, you're able to reach certain areas which are hard through open surgery. For example, doing a hiatal hernia surgery, it's a small pretty straightforward surgery, but you have to make a very large incision just to get to that spot. So laparoscopy overcame that hurdle. Same goes to cholecystectomy. You're going to create a large wound just to get rid of the gallbladder. So these added benefits of laparoscopy made it more popular. And more importantly, it is a good tool for teaching. I'll explain later why, right? So the key differences between open and laparoscopic surgery, basically dividing into certain components. In terms of the patient, of course, smaller incision will result in less pain. Patient like it, less analgesia. And then one important aspect we have to understand is the cellular and molecular level. The larger the incision, they are more likely to result in larger inflammatory response. So that will worsen the patient condition, get them back on their feet slower. You will need more inflammatory medications and all that. So all these we are able to reduce through laparoscopy to the smaller wound. And then once again, smaller wounds facilitate early return to activity. And of course, a less chance and incidence of developing surgical site infection and incisional hernia, which can be a big problem in the future. The benefits of laparoscopy for the hospital or management. Yes, in the beginning, it may appear a bit tricky. You know, you need to buy a lot of instruments, you need to buy the laparoscopic tower, etc., etc. But when you look at the overall cost and the long-term cost, which translates to reduced length of stay in the hospital, the reduced use of analgesia and antibiotics, on the long run, you will find that the cost is much better for the hospital. And what about the surgeon? You know, surgeon, we find this very important aspect of surgery, and laparoscopic surgery gives you a magnified view of what you're doing. And because your view is better, it allows you to perform surgery better, and more importantly, precise type of surgery. It can result in less bleeding because you're very focused into the area which you're looking into. And teaching. In the days of open surgery, only the surgeon, assistant, and the nurse probably can take a look exactly what's going on. So when we talk about laparoscopic surgery, the entire surgery is displayed or broadcast in the monitor. So everyone in the OR, right from the surgeon, anesthetist, your nurses, you know, the attendants, everyone can see the surgery, and it's a very good tool for teaching. And that is why laparoscopy bloomed very fast, you know, as compared to other surgeries. All right, OR setup, I won't go into details, but probably this would be what an ideal OR setup will look like. A very large, spacious room, a bright room, enough lighting, preferably monitors on both ends of the room, and as much as possible, you are able to move these monitors in case, like what Dr. Sujit says, surgeons sometimes may need to move from left to right, you know, front to up to down. So if you are able to move those monitors, even better. And if it's good, if you have these suspended towers and things like that. So this would be an ideal room. But of course, sometimes our room may vary based on the our institution and all that. But we try our very best to make do with whatever we can do. All right, let's go to the main components of the this whole laparoscopic surgery. So the main components will include two main parts, the laparoscopic tower as well as the instruments. All right, the tower will consist of the main bulk of the unit. It will consist of the monitor, the video camera, the light source, as well as the insufflators. And the instruments are basically those that you use to create access into the abdomen, surgical ports, instruments, as well as energy devices. But I'm sure many of you are familiar with the laparoscopic tower. The topmost will be the monitor. You started off with very small monitors, 14-inch, 15-inch, you know, back in the day. And then now it's gotten bigger, wide view, and much clearer monitors to provide more accurate and precise surgery. Next, you see the light source below there. So this is where the light is emitted through some cables and illuminates the abdomen, because you know the abdomen is a dark cavity, so light source is very, very important. So next, video processor is where the camera project the light from the light source enters the abdomen. Camera picks it up, sends the signal back to the processor, and that is what it is projected in the monitor. Insufflators, very important component. I think like what Dr. Sujit already explained. You must have a backup oxygen tank at the back and various components. We'll go into details a little later. All right, monitor has come a long way since the first camera system came out. Nowadays, we have high resolution monitors, mainly to produce better image. The better the image, the better your surgery, you can see clearer, and the bigger the monitor is even better. We have 3 chip cameras now, which provide 3 different type of color combination. I'll explain later. Nowadays, with the technology of high definition, your image is better and you can do much clearer and precise surgery. And now we have newer technologies, Ultra HD monitors, the 4K system, as well as 3D monitor system. All this is basically to give you better view of whatever you're doing in the abdomen. Other accessories which you may add on will be like video recorder, CD, DVD, and then USB device to record your surgeries. Okay, that's a basic monitor. I think most places will have something like this. All right, next we go into the video camera. So basically, camera captures the image from the abdomen, is processed and then projected into a monitor. And it is a live feed basically, all right? There cannot be any interruption, cannot be any delay in it. This is a common video camera you see. I think most of you might have this in your centers, all right? So, and it is attached to the processor. The better the processor, the better the chip, the better your image is going to be. This is just to break down to show you the key components, all right? So the top part is attached to your telescope or the camera. You have your focusing paneling here, your fine focusing over here, and then we have certain programs. The previous ones used to have less program, and then the newer ones will tend to have better and newer programs depending on what instrument you get. All right, light source. Okay, main thing we need to worry about light source is that it produces heat. So the older version, they provided good light, but unfortunately they have produced a lot of heat. So that can be a problem when you're dealing with the abdomen or when you accidentally touch the bowel or any other vital structures. It can be dangerous. So the newer ones like LED lights tend to produce less heat, better illumination, and it tends to last longer. So this light, they are delivered from the processor to the camera through fiber optics cables. Okay, so these cables, as far as nursing is concerned, you should look after it well, teach the juniors how to handle them well. Why? Because it is made up of glass fibers. So these fibers, you must take care. Any improper handling can break these glass fibers, and then you will need replacement. Right, this is the light source, the common ones with majority of the hospitals have. And that is the cable which I was mentioning. It should be ideally rolled up in layers and kept. It shouldn't be bent, or or should take care to clean it. It shouldn't chip off. All right. So if not, probably they're going to have to cut your salary if anything is wrong. All right, just introduce you to this thing called white balance. I'm sure you have heard many times in your OR, your surgeon say white balance, white balance. What is this whole concept of white balance? We go back to physics. The 3 main colors, okay? When you converge them, it produces white light, and that is what you want. I think Dr. Sujit mentioned just now, sometimes the colors tend to skew if you don't balance these 3 colors together. All right, if you don't white balance them well, you may get a red hue or a greenish hue. All right, so you don't want them during surgery. So very simple. Most of these systems, you just have to illuminate it against your white gauze, press the white balance button, and then everything is standardized. All right, insufflators, okay. We use carbon dioxide, okay, because it's cheap and it's safe and it's absorbed and expelled very easily through the body system. Oxygen is dangerous, so carbon dioxide is the gas of choice. This is how it looks like. Different insufflators have different, but generally most of them will have the pressure, the volume, and then the flow rate. All right, this is another one for Olympus showing you the different components. All right, so pressure, you see on your far left is the amount of pressure that is produced and maintained in the abdomen. The middle one is the flow rate, meaning to tell you how much of air, CO2 you need to flow to maintain that pressure, as well as the volume. Okay, we try to keep it at a very optimal. The more you're going to insufflate inside is going to cause some physiological abnormalities, and patient may not do well after surgery. So pressure for generally adults, we keep it between 10 to 15. 15 is the upper end. Sometimes in bariatric surgery, you may tend to go a bit more, but always do it with caution. So sometimes junior surgeons just picking up, they may not be aware of this. So that's another role of a nurse, MIS nurse, is to keep all these things in check. Children, we tend to keep it a bit lower, 8 to 10. Basically just enough of pressure for you to carry out your job. And of course, keep an eye on it. And then, like what I mentioned, if there's too much air, it's going to cause compression on your major vessels, your heart and your kidney, and you don't want that at the end of the surgery. All right, surgery may go well, but patient may not recover. That's not very good. Flow rate, okay, basically how much of CO2 you produce and you shoot it into the abdomen. And then usually it's limited by whatever you use. Varys needle only allows about 1 liter per minute, 2 liters per minute. But when you use a bigger trocar, because of the bigger lumen, you can shoot in more CO2. So very be careful with how much you do. Safe practice is to start slow and then gradually increase the flow rate so that your patient also can adapt. So the total volume, basically, it can range anywhere between 1.5 to 2, depending on what procedure you do. The bigger they are, the thick abdominal wall, you may need to go, but always be cautious, usually not more than 5 to 8. All right, so we're done with that component. Now let's move on to instruments, okay? I've broken them down into the basic instruments that we use, and we will go through them one by one just to see what is it. All right, so telescopes comes in various sizes. Common ones which we use is 10 mm telescope and 5 mm telescope. And what's important is the capability. Okay, I'm sure you're very familiar. Your surgeon saying 0 degree, 30 degree, and all that. So the commonest one we do is use is 0 and 30, and sometimes there may be slight variation, 45, right up to 120 degrees, depending on what surgical procedure the surgeon is doing. So that's how the telescope looks like. We have 3, 5, as well as 10 mm telescopes. All right. So what I was trying to explain to you is the 30 degree and 0. So a 30 degree camera will look something like that. Okay, the end is just flat. That will give you just a one-way view. But when we look at a 30 degree camera, it looks something like this. Okay, the tip is slanted. So that will give you a more better view of your surroundings. But it takes some time to get adjusted. You may get some scolding along the way because it's not easy to move and all that. But with practice, I'm very sure you're able to get it. Okay, so that's what I was trying to talk about. 0 degree, you just look straight up in front. 30 degree will give you some angulation, and that angulation is beneficial for you to move around and to look while doing the surgery. So the proximal end will be attached to the camera head. Okay, in the past, surgeon used to just look at it through there and do surgery, but now we connect the camera head to that, and that is projected on the monitor. All right, so next we go into creating the pneumoperitoneum. Pneumoperitoneum is a very important aspect of laparoscopic surgery. You can't do surgery without pneumoperitoneum. So there are a couple of ways which we do it. One is the closed technique, the other is the open technique. So in closed technique, what we do is we use a Varys needle. I'm sure you're familiar with that instrument right there. You make a small puncture into the abdomen. Make sure you're not hitting any bowel by doing a saline test. Once that is confirmed, we insufflate the abdomen very slowly. And another way is by using the open technique. In open technique, basically we just not very clear. We incise the area of interest, and under direct vision, you go layer by layer until you reach the abdomen, and then you insert your ports or your trocars inside. It's very safe. Just takes a couple of more minutes extra, but ultimately you have a safe entry, and that's what you actually ultimately want. Okay, another picture showing you go layer by layer, and then you introduce your trocar under direct vision. Another way that we use is called the direct entry or the optical port. As you can see in picture A, the telescope is inserted into the trocar. Incision is made on the side of interest, and then we gradually push the trocar in under direct vision. So on the monitor, you can see the whole thing being done, going into layer by layer. That's to be done by caution. It takes some practice, and best to be avoided in cases with adhesions or previous surgeries. All right, so now to perform the surgery, you will need trocars. Okay, so these trocars comes in various sizes and materials. Sizes, how we gauge them will be based on the diameter. We have small ones as small as 3 millimeters and right up to 12 and even 15 millimeters in bariatric surgery. It consists of a shaft, body, and blade. So there are different types of, lots and lots of types of trocars in the market. Okay, but broadly we classify them into cutting, muscle splitting. Okay, the type of trocar, disposable or reusable. In the past, it started off as cutting. The trocars are sharp, and as you enter, it cuts the layers, and then that will facilitate the entry. And then it's very traumatic, and because of that, muscle splitting trocars came into picture. It's less traumatic. It doesn't cause much harm, not much bleeding, and it's more popular nowadays. All right, you can see those pictures. The top one are sharp ones, which are traumatic, can injure the bowel if not handled properly. Because of that, to overcome those problems, the non-bladed or muscle splitting trocars come into picture. So basically just twisting motion, and it enters the abdomen very easily, and more importantly, not much damage to the underlying structures. All right, another picture showing you the type of trocars, metal trocars, which are sharp. Good thing about this, it can be reusable, but must be handled with care. And disposable trocars, nowadays, many companies are coming with it. It's a single use, you use and you dispose. Sometimes may not be that good if you're talking about being an e-hospital or cost saving, okay? Because it's plastic, and then you dispose, you add on to your hospital waste system. All right, now we move on to the operative instruments. There are many types, but broadly we classify them into graspers, which you use to grasp whatever tissue you're using, dissectors to dissect your area of interest, scissors, monopolar instruments for energy, clip applicators, retractors, suction, and etc. All right, so this generally how a laparoscopic instrument will look like. Okay, you have the handle on one side, you have the shaft, and then the tip is where you execute your surgical, your area of interest and the type of surgery which you do. So graspers basically for grasping tissue and to retract, they can be divided into traumatic and atraumatic depending on what sort of tissue you're using it for. And it is because since you're holding something, it's best attached to a ratchet because to keep it in place. All right, there are many types. We have this, the intestinal graspers, which you see looks safe and atraumatic, doesn't cause any damage. And then you have those sort of traumatic graspers. So traumatic graspers, we mainly use it for hiatal dissection where you want to hold the liver up, or you want to use a gallbladder surgery to retract, or in the fallopian tube or the uterus, something thick tissue that can withstand the grasping. So this, since you're going to be grasping the entire surgery, is best attached to a ratchet to facilitate with the surgery. Okay, another picture showing you the different types of graspers. Now we come to the atraumatic bowel graspers. So these are very important. Most of us deal with bowel in our surgery. So the type of graspers you use are very important. It should not, bowel is a very fragile, must be handled with care. So just as that, your instrument must be made in a way that it is safe on the bowel. So it's atraumatic. Now when you're using it bowel, you're going to be moving it up and down. Bowel tends to move, slip. So ideally it should not be ratcheted so that it can facilitate. By mistake, okay, if there's a ratchet to the bowel and you just click the bowel there, not knowingly, that's going to cause damage to the bowel or blood vessel or something like that. So sound knowledge on these instruments sometimes is vital, not only for the surgeon, but for also the nurses. So you can always advise, especially junior surgeons. Okay, dissecting forceps is important to do your surgery. It's usually used to create spaces, to dissect tissue, planes, or sometimes to skeletonize structures, such as cystic duct or artery and things like that. So it has to be safe, blunt, not to cause any underlying trauma to the surrounding tissues as well as the main tissues. All right. So these are the commonly used dissecting forceps, the Maryland forceps, as well as the right angle. So this is how the Maryland forceps looks like. It's best to have one or two in any set that you use, because almost every surgery we will use this Maryland forceps. Dissect the right angle one forceps also is another common instrument, can be useful for dissecting tubular structures, the common bile duct, your cystic duct, things like that, ureter. So another good tool to have in your set. Now we come to monopolar electrodes. So these electrodes come in many different types of tips. You have your L, J, spatula, and things. So depending on the surgeon's preference and the type of surgery you do, ultimately they work the same, but depending on the type of surgery they do, you can choose and equip your laparoscopic sets with one or two of these. Bipolar forceps, another good instrument to have because it is safe on your tissues. There's not much of lateral spread of current, and is good for dissecting around important and vital structures. Retractors, there are many types. This is a common retractor we use to retract the liver, the uterus, and any other bowel. It is safe and I think not very expensive to purchase. There's another retractor that we commonly use, the Nathanson's retractor. So this comes as a separate supplement, if I'm not mistaken. So if you're not familiar, best not to use it. Scissors, pretty straightforward. We have a straight scissors, curved scissors, as well as hook. This is how they look like. So depending on its function, tissue scissors tend to be different. Suture scissors tend to be different. So be familiar and familiarize yourselves with those scissors. Energy device, a very important aspect of a surgeon and surgery. So the two commonly used energy device are the ultrasonic ones. Okay, so what does it do? It uses ultrasonic technology to produce heat, and that heat is used to cut and coagulate. It's very precise, but be aware about the lateral spread of thermal injury. Sometimes, when after we perform some cutting or coagulation by mistake, that ultrasonic shear is left on the bowel, it can cause delayed perforation. So it's good that the nurses also be aware of this. Bipolar or sealing devices commonly used are the ligature, bisect, and trisect. It's very safe. It's another form of bipolar instrument. Not much of lateral spread. It's quite safe, and many of us use this as a Maryland as well. So you can dissect tissues as well as use it to seal vessels. Okay, this is how it looks, the harmonic connected to the device. So these devices as well should be well taken care of, kept at the right side of the patient and the surgeon. The wires should be tucked in well so that there's no leakage and no damage to these machines. That's how a ligature looks like. Okay, you can use it for dissection as well as for vessel sealing. BISAC, another very common, not very common, but many of us find it very useful because it's a form of bipolar. Only thing is you need a pedal for it, and it is reusable, so it's good for hospital and patients' finances, purchasing and stuff. Other miscellaneous instruments that you can have in your set will be the Babcock Forceps, good for the appendix or for gynae surgery. Suctions, they are simple ones as well as some more advanced ones. Retrieval systems for gallbladder surgery, use the endobag, endoloop for your appendix or your gallbladder stump, as well as clip applicators. So Babcock, good for appendix or to pick up the fallopian tube, things like that. Won't cause much damage, quite easy to use, ratcheted, saves your energy. Endobags, there are plenty of them in the market now, depending on your suitable finances and your budget, you can get them. Clips are very important role to prevent bleeding and for gallbladder surgery. We have these Hem-o-loks which come in various sizes, as well as clip applicators where we use the titanium clips. Endoloop for gallbladder as well as appendix. And yeah, so that will go on to the OT arrangement. I think Dr. Sujit already explained a few. I won't go into detail. So for cholecystectomy, basically the surgeon stands on the patient's left. The screen should be what is there. You see marked A. Assistant on the side of the surgeon. The second assistant on the opposite side, and the tray should be at the bottom. Trolley. Right, this is laparoscopic cholecystectomy with IOC, pretty much the same, but you must leave some room for the II or the C arm to come in. Appendicectomy, pretty simple. The monitor is placed on patient's right foot or on the patient's right. Surgeon stand on the patient's left. Scrub nurse and assistant on either side of the surgeon. Laparoscopic hernia repair, I think Dr. Sujit already mentioned. Anterior section, patient should be in a Lloyd-David position, should have the good stirrups. Ideally, we have two monitors, one for the surgeon, one for the assistant, and then instrument table opposite the surgeon, and leave some room for retraction as well as for the main assistant. Right, so come to the end. So it's very important to familiarize yourself with the instruments and all the necessary adjuncts to laparoscopic surgery. When you are aware of these kind of instruments, how to use them, how they can damage, what injury it produces, you not only make it safe for the patient, but it's a team. You can inform the surgeon, or you can teach junior surgeon regarding all the important aspects of laparoscopic surgery. So always be aware of problems that can occur, and then in anticipation, communicate with your surgeon. So I'll end right now, and if you have any question, we can take them now or later, or you can send us an email. Thank you. Okay, so I think we have come to the last topic for today. That'll be by Dr. Gafo, MIS surgeon, bariatric surgeon, and he will guide us on the aspects of laparoscopic setup for bariatric surgeon. Gafo, welcome.
Thank you, Dr. Mark. Thank you so much, and greetings to Dr. David, Sujit, and Mashfiq, and to all the nurses who and also paramedics who are joining us today from across Asia. Please let me share my screen. This bloody new Zoom, a bit difficult for me. No, that doesn't work. 1 minute, sorry. Let me just new share, sorry. Okay, let me do it again, sorry. Okay, can you see it?
Yeah, can see, clear.
Okay, great. So overview of bariatric surgery and troubleshooting for nurses. So basically, bariatric surgery, as you all know, surgery dealing with obesity and metabolic diseases. And the ergonomics of bariatric surgery is somewhat a bit different as compared to the ergonomics of doing normal, other surgeries, mainly gallbladder and hernia. So the reason is because patient is generally very big and space is an issue, camera system, and also positioning and skills involved in the OR is a bit different as compared to conventional procedures. So I'll try to split it up into introduction and in some differences in conventional laparoscopy and bariatrics, some key skills that I think nurses is good to have, adjusting from general laparoscopy to bariatrics, how to manage some surgeons, how to manage OT time, consumable, and the importance of now having skilled nurses and paramedics for this. So as you know, in Southeast Asia, Malaysia is one of the fattest nations, but is very closely followed by Thailand and even Singapore, Philippines, and Indonesia. Therefore, bariatric surgery is gaining a lot of popularity, and there is more OT time, more OT usages, and more demand for bariatric surgery as opposed for other surgeries. So there is differences in conventional laparoscopic and bariatric surgery. In ward, there are movement and slides. So because patients are very big, you want to be careful in moving them. So when you move them in the ward, especially to OR, there is the need for maybe slides, because some patients are so big, they cannot move on their own, their mobility is restricted. So there must be some investment into slides that can assist patients to move from bed to bed. Therefore, and also this helps to increase the longevity of our nurses, because nurses are not very big. Generally, they are normal BMI, they are small in size, and they have to move these big patients, and normally they are female as opposed to male nurses. Second is medication dosage. In the ward, as opposed to conventional cases, dosages of medication for patients with bariatric may be different. The same pain relief dosage for normal conventional patients may not work for bariatric patients. So patients, even after you administer the pain relief which has been ordered by doctors, you will wonder sometimes, why is the patient still in pain? And sometimes nurses and also even doctors are in the ward, we tend to tell patients, oh, don't worry, everything will be okay, we already gave you the pain medication, but actually the dose is not enough. So when this happens, the patient doesn't receive enough analgesia, or in other terms, enough antibiotics or antiemetics for the reason, but yet and so it will not work. So patients will still have pain, vomiting, still have fever sometimes, and things like that. So medication have to be very careful, and sometimes we have to remind doctors, doctors they like to forget. So I have to remind them, doctor, maybe the dose not enough for this patient. What do you think? That kind of stuff. Late signs of problems, these are the other interesting and important difference between conventional and bariatric. Patients that have got problems in bariatric, normally the conventional signs, for example, in bleeding, we depend a lot on tachycardia as well as low BP. But these are all very late signs in bariatric. Patients that have got big abdomens, it'll take time for the blood to fill up and cause compression onto vital organs, and then only manifest as symptoms. So any small problems in bariatric patients, namely in pain, or patients feeling anxious, or they vomit out maybe weird things like blood or things like that, have to be taken seriously as opposed to conventional patients. Falls and prevention. As opposed to conventional treatment, bariatric patients, especially post-op, they're very heavy. They are very prone to falls, and we have to make sure that even the cleaning fluids on the floor are not slippery and can induce fall in these patients. And we have to be very careful when we move these patients to surgery and back. Again, because of falls, because of faultiness in beds, sometimes when we are not used to it and we are not aware, when we move them from bed to bed, those beds might break, because they are so heavy. So we have to be careful to choose proper beds actually. In operating, Theatre, everything is bigger. You know, the tables are bigger, the instruments we use are longer, the straps are bigger. Only the doctor only remains the same size, and the nurses. Generally, everything else that we use is usually bigger. And again, I want to emphasize slides and movement because these adjuncts will help with these patients. Proper monitoring in recovery. I find that many OTs tend to disregard the importance of monitoring bariatric patients in recovery by having proper equipment, especially big BP cuffs. So BP cuffs that are conventionally available are normally not suitable for bariatric patients. Their arms are very big, so it does not have a secure strap, so you're not able to monitor these patients well. So investing very carefully in this is very important. If you don't have, ask your hospital or ask the ward. They might have those cuffs or those monitoring devices to bring to the OT to help you. And lines and IV access. Never take lines and IV access without any, never take it for granted. Because in bariatric patients, if you don't have a line and IV access and then you revert to oral medication, often it is not enough, especially when you want to manage post-op patients. So what are the key skills that I think you need to have as a nurse to manage bariatric patients? Familiarity with complications, in the sense that you need to know that these patients are prone to some very unique problems that only they are prone to. The one that is very common is DVT. So obese patients are very prone to DVT. Coupled it with long surgery for bariatric, it is actually a double strike, and they are very, very prone. If you do not have any type of prophylaxis, you have to trigger the surgeon to at least give instructions to mobilize the patient early. And if it is unable to, you must tell the patient, the surgeon, this patient has had 3 hours surgery for bariatric, patient is 180 kilos and she is not moving. What do we do? So some sort of mechanical or pharmaceutical DVT prophylaxis must be given. Like I mentioned before, managing dosages and nursing care. What I mean by managing dosages, I've mentioned before, nursing care is very important to these patients because psychologically they are very sensitive. They've got a very poor self-esteem and self-image consciousness, and so nursing care towards them has to be in a very soft way, soft and firm, so that you can get your message across. Which leads me to understanding obese patients, their mentality, their psychology. Many a times they come with very bad diabetes. Many a times they come with other metabolic problems, but they are not so big. They look small, maybe because they have got more muscle, they have worked out, so they look so. Very important element is when you greet them, it is already a very traumatic experience. You cannot trigger them by saying that, oh, so big, why are you doing this operation, for example. So you have to be careful. And always have these considerations for pain management in these patients, because pain is the number one reason why a lot of things go sideways when you have post-op bariatric patients. Normally they don't have any other problems but pain is the first trigger to maybe having fever, and then subsequently after fever they will have problems mobilizing. When they don't mobilize, they've got respiratory problems. So if you had managed the pain in the early phase, all this would not have come to any problem. So Dr. Mark has mentioned a lot on instrumentation. Dr. Sujit has also mentioned regarding ergonomics in OT. Now, what are the OT nurses adjustments that I feel they have to pay attention to in the OT? Number one is they have to be very familiar to use a 30 or 45 degree camera, lens. They cannot use a 0 degree that extensively like how we use it in other operations. 30 or 45 degrees is the way to go because you need to angle to see at specific places, and so that is the way that you have to do. Number two and number three is pushing against fat, because many a times our lens will not be able to reach a particular view. You need to push against the fat from the outside to achieve it, but you need to do it in a way that doesn't disrupt the view or cause anything to shake. So this requires some skill, some getting used to. So the more operations you do, the better. And managing the camera around fat. So there's a lot of fat and the omentum is normally very thick in these patients. You have to find a way to maneuver your lens around this particular element so that you are able to get the best optimal view. You are fighting against the patient's own weight. You are fighting against the patient's own fat, so you are also not so big sometimes, so you have to use a bit of skill to obtain your way around it. So how do we manage bariatric surgeons? Number one, they are creatures of habit. So bariatric surgeons they want the same thing normally. They do the same operations. So normally the flow in their mind is for the same sequence of events during the surgery. If you have the same sequence of events, means you need the same instrumentation. And often at times, they don't like much variation. Number two, it is easy for you all to have a flight checklist model. That means if you can't remember what a particular surgeon wants, or during that particular procedure, like doing a sleeve or a bypass, you can actually jot down as a checklist, and you can actually tick off the checklist as you go along. I find that this is how I train new nurses, and I find that they are able to adapt much faster than them trying to remember and trying to think what is next. So this checklist model is very, very good. Now, most of the cases are same but different. That means the variability in the weight makes it different, but generally the steps are the same unless you come into problems. Maybe you'll come into problems maybe 5% of the time, as opposed to doing other operations like gallbladder, hernia, cancer surgery. You can come into problems easily about 30 or 40% of the time. But bariatric, normally there'll be a variability only in about 5%. So always try to maintain a routine, a same routine, so that there will be some familiarity in doing the next procedure, and you become better and better and better. How do you manage OT time? That means your surgeon wants to do a bariatric case, and you want to do it for him, but other surgeons want to do case, and it is a unique situation because bariatric requires a lot of preparation. Maybe a sleeve or a bypass might only take 40 minutes or 1 hour, but preparation might take about 1 hour, 1.5 hours, bringing the patient in, positioning, strapping the patient, intubation, cleaning, because a lot to clean, they're very fat. So dedicated OT is very important. If you have a case for bariatric on that day, keep the OT dedicated for bariatric, unless you have to include some other emergencies into that OT at that time. Normally, if you include other elective cases into a bariatric OT, it becomes very frustrating for the waiting surgeon. Not because of anything, the surgeon will call the OR and ask, Dr. Gaffo has finished his case, finished. Then why so late? I have to wait. He finished the case already, what? But they don't understand, even though we finished, to move that 180 kilo patient into a bed, to move them out, to decannulate them, to keep them monitored for a while, takes a long time. So it has to be a dedicated OT if you're going to do it that day. Preparation and dedicated team. The nurses cannot be shared. It must be on that day. If those nurses are fit for the bariatric team, it has to be for that. If they're moved around, it's difficult, especially when you get into problems. You need a big team to support. For example, if you have bleeding, you might need different pots which were located in the storeroom. You might need energy devices that are new. You might need clips. You might need you might need an extra assistant. You might need to insert. So this is why you need a dedicated nursing team when you're doing that particular case. And the recovery must be prepared for obese patients. It must be a suitable recovery area, not for general patients that you park a bariatric patient there. It must be suitable. The space must be big. Monitoring must be, like I mentioned, with good size BP cuff. And there must be a need or a availability of asking for help. That means if you need other people to come and help you during an emergency, you have maybe a call button or what to help you during that time. Because generally airway problems in recovery for bariatric cases, if they have problems, they normally go downhill very fast. So my message here is we need more nurses lah, especially for bariatric. In Malaysia and a lot of Southeast Asian countries, the Singapore and Saudi factor is very strong because of the heavy recruitment in this country. A lot of skilled nurses, they would like to join the workforce in those particular countries because the pay is much better, especially with regards to currency conversion. It is the practice must be more than just work, because changing lives in bariatric is not curing cancer, it's not removing a hernia, it's not removing a stone, is by changing a lifestyle. Patient is a healthy patient, but they come to become healthier. So we have to assist them in their journey. It is an experience rather than coming in to have a procedure done. So we have to think of it that way. So when they come, we have to have that mindset where they have to be supportive. And this is a skill that has to be learned by our nurses and paramedic rather than treating everyone the same way. Same work and some may be bought. So it's not a job for everyone. So some people like variability and differences in their day-to-day work. But when you do bariatric, normally you are people who like habits and you like the same thing. So it's different. It's not basically for everyone. And some must have the need and the satisfaction to treat obese patients. So this will help you to actually give them better care and also better service so you can get better results. So I've come to the end of my presentation, and I would like to thank um, everyone for listening. And let me just try to get out of this thing now. Stop share. Okay. And if there are any questions, I think I'll be more than happy to address them. If not, I
Thank you.
pass it back to Dr. Mark.
Thank you, Gafur. Very nice. You spoke on very pertinent things, sharing stuff and all that. All very, very important things, especially in private practice where staff is limited. We need to move them around. Okay, great. If any questions from the floor? I don't see anything on the chat or any hand, but if you do have, please do email to us. We will gladly answer them. If not, we have finished ahead of time. I'd like to thank all the speakers for being here today, for making this smooth. And I will see you all tomorrow. Okay, can you just hold on? I'll just take a picture. Prof, ada? Prof left, Not
He
sure.
said, I think he has something on.
Something on. Okay. All right. 1, 2, 3. Okay. Thank you, guys. Thank you. So I'll see
Thank
you
you.
all tomorrow at 2 o'clock again for the endoscopic part. Hi, Masvik. Nice to see you.
Nice to see you
Okay.
last week.
See you all tomorrow. Bye. Bye.
Bye-bye.
Gopur, off the camera, please. Okay, no, it's okay.
Oggi nulla di che, stiamo... non ci abbiamo i biglietti, quindi non si può fare.